Ramesh. This is Dr. Fawziya Al-Kandari from Kuwait. So we are in the meeting now.
Good afternoon.
Good afternoon. I know it's an early morning there, and it is an afternoon time here. So I would like to introduce Dr. Ramesh Hariharan. He's a professor of medicine and the head of cardiac electrophysiology in Houston, Texas. He is going to talk to us today about an overview and outcomes in atrial fibrillation and his local experience and different modalities of AF ablation using radiofrequency, cryoablation, pulsed field ablation, and also a hybrid procedures. So most welcome, Dr. Ramesh, and we are looking forward for your presentation.
Thank you very much. Is there an echo in your room, or you're hearing me okay?
I think, I don't think so here. It's okay.
Perfect. So first of all, I want to thank you all for inviting me. It's wonderful to see Sama flourishing thus. She was our fellow, and it was outstanding to see her, go back to Kuwait and set up a AFib Ablation Center, and it was really a pleasure when she invited me. It was wonderful. So thank you for inviting me. Let me talk about a couple of things. I see, I only joined for the talk before, so. Can you hear me?
Yes, we can hear you, definitely. Yeah. And we have your presentation.
No presentation on AFib is going to be appropriate without giving credit to Michel Hasek-Guerre, whose seminal paper in 1998 in the New England Journal of Medicine, this is about the time I joined my fellowship.
Recording in progress.
Showed the fact that the origination of the ectopic beats that caused atrial fibrillation they identified these beats that came a few milliseconds before the onset of atrial fibrillation. Give me 1 second.
Sure, we still have you.
Okay, so I won't get into too many electrograms, I promise you, for those of you who are not, but they identified discrete signals in pulmonary veins that would consistently precede the onset of atrial fibrillation. And although the initial approach was to try to actually take out that signal, we have learned that we want to try to stay outside the pulmonary veins, as your speaker immediately before me presented, to avoid pulmonary vein stenosis, and therefore the term pulmonary vein isolation was born. The origin relates to the interdigitation of the muscle fibers between that of the pulmonary veins and the body of the left atrium, and the aim therefore was to try to isolate those veins. And so that's the basic requirement for try to electrically isolate without impeding the mechanical flow, to try to obstruct the egress of the signals from the pulmonary vein osteo. So obviously this lends itself to ablation, which can be performed with a variety of different options. It is the original tools that we had related to radiofrequency ablation catheters. Technology has significantly improved, and I'll try to cover some of those aspects, but the basic requirement is to achieve electrical isolation with both entrance block into the pulmonary vein and exit block from the pulmonary vein. So we typically create lesions and demonstrate these two concepts. This is a cartoon demonstrating an original circular lasso catheter with radiofrequency ablation catheter to achieve isolation in the region of the left upper pulmonary vein. We, at least in my practice, I don't use the lasso catheter anymore because we have much better tools in terms of higher density mapping, so that we don't have these gaps between the electrodes. We can actually map this at much higher density now. So cryoablation came on as a tool that was a little bit easier to handle, and you did not need to worry about you trying to maneuver a 3 millimeter tip catheter across the ostium of pulmonary vein. You could use a shotgun approach so as to take a balloon in the range of 28 millimeters, basically transiently apply yourself to the orifice of the pulmonary vein, and depending on the level that you can have a tight fit into that pulmonary vein, at the ostium or antrum of that vein, you can generate temperatures down to minus 60, and effectively you can watch the pulmonary vein become dissociated if you have a mapping catheter distal to it. So this paper presented in the New England Journal of Medicine from a couple of years ago demonstrated the proof of concept in terms of a prospective evaluation with a significant benefit in patients with atrial fibrillation. This study was originally done in patients with paroxysmal atrial fibrillation, and more recently there was the stop persistent trial with the cryoballoon therapy for patients with persistent atrial fibrillation as well. More recently, we have, until recently, the only technology for cryoablation that was available was the Medtronic balloon. And this paper talked about the experience with Boston Scientific that wanted to enter the realm of cryoablation as well. And this is the experience with the polar ice catheter, the polar X catheter. And the advantage of this system is that because they have integrated VersaCross, you can actually go in with the same sheet transeptally, and then you have a more deflectable sheet. And because it is a newer console, some of the data is automatically integrated in the report that you get. But it achieves the similar results in terms of very comparable results in terms of pulmonary vein isolation, with a balloon occlusion of the pulmonary vein that then and it has got a mapping catheter at the end, and you can combine it with other mapping catheters to improve the higher density that you would require for better fidelity of saying that you've truly achieved what you set out to do. This is a slide from a arrhythmia mapping system that is also Boston Scientific that looked at extensive as you can see in this picture, for those of you who don't come into the EP lab, you want to see more purple and you want to see less red or gray. If you see less red or gray, that means your vein is electrically dissociated. This is a posterior view of the left atrium with the the left upper and left lower pulmonary veins on the left and the right upper and lower veins on the right. So obviously paroxysmal atrial fibrillation is a better beast to handle because there has not been significant remodeling of the atrium. Unfortunately, we don't always get referred these patients. We get patients referred after, unfortunately, sometimes years of atrial fibrillation. And so one plea I would make from the standpoint of an electrophysiologist is, if you wait for challenging with first medicine, the second antiarrhythmic, third antiarrhythmic, 3 cardioversions later, and then refer the patient for atrial fibrillation, your results are going to be definitely worse than if you identify a patient that would benefit from atrial fibrillation and refer them to an EP associate of yours sooner. Your experience and the patient's experience will be a lot better rather than waiting until you have the whole gamut of atrial stretch, atrial inflammation, fibrosis, and then model of persistent atrial fibrillation. And so your work is harder if you wait longer, as you wait longer and longer, because you continue to allow this process to fester. And this model is called the stiff model, which relates to stretch, inflammation, fibrosis, and fibrillation. I think the previous speaker already covered this. I won't get into too much of this. And this is again from the Utah group with Nasser Marouche and late gadolinium enhancement to look at degree of fibrosis. Paradoxically, when you have stage 4 with more than 30% of the atrial wall fibrotic, there is a significant thrombotic risk even when the patient demonstrates P waves on the EKG. When you look at the fibrosis in these patients, and of course this is a cartoon trying to simplify this concept, but a lot of the posterior wall in the area real estate between the 4 pulmonary veins and in the vestibule anteriorly are the ones that are incorporate the most fibrotic tissue. Believe it or not, even in 2016, and the next slide will show you that in 2022, we're still understanding the complexity of the layers of muscle. And this is from a paper from a few years ago in terms of the complexity of the subendocardial, subepicardial, and epicardial muscle bundle layout. This is from a paper just last year in terms of looking at the complexity and relationship between the septopulmonary bundle in the dome of the left atrium and the septal atrial bundle, and looking at adipose tissue in between. There are specific comments made in this paper about that. This is, I say even as of last year, because you would have thought that there's nothing more to learn about the anatomy of the left atrium, gross anatomy. We're still learning about it. Epicardial adipose tissue is an interesting concept because it is not like adipose tissue in the subcutaneous space for sure. It is a complex structure that is electrically conductive, contains autonomic plexi. It is able to communicate with the left atrial myocardium, and it is actually difficult to reach from the endocardium. So it is still something we're learning about. This is a cartoon depicting some of the complexities that we deal with, as I've mentioned, in terms of muscle fibers, but we have the autonomic nerve plexus, the left superior GP, the left inferior GP, the right anterosuperior GP, and the right inferior GP. And the venomarshal would actually be your 5th GP, because that is the input of the adrenergic system. The other ones depicted in yellow are your input of the parasympathetic system. And of course, variety of other mechanisms that can participate. Non-pulmonary vein triggers are shown in these green stars. And then of course, you have potential rotors and other complex mechanisms. Now, if you want to target this area, especially if you're referring your patient for consideration of ablation because you just decided, or the patient just decided this would be a good time after many years of AFib, then unfortunately, pulmonary vein isolation alone is sometimes not helpful, or at least we don't know yet. So a lot of EPs tend to target the posterior wall, in the concept that embryologically, the posterior wall of the left atrium originally was sinus venosus and pulmonary vein tissue, and it does identify and behave like pulmonary vein tissue from an EP standpoint. And so it was a sensible consideration to say, let's ablate the posterior wall. The problem with that is that immediately behind the posterior wall is the esophagus, and that's why we do transesophageal echoes, so that we can peer into the left atrium, because the left atrium is immediately anterior, and the portion of the left atrial wall in that area is about 2 or 3 millimeters in thickness. So even though the posterior wall is targeted, we find that studies that have specifically looked at the impact of posterior wall ablation have not shown to be as helpful as we would have initially thought. makes sense to say, okay, the left atrium is remodified, and so let's target some tissue that is besides the pulmonary vein ostia. But one of the things that immediately you expose yourself to is the high risk of atrial esophageal fistula, and that is one of the most horrendous complications to see somebody with this. And I'll come back to that concept in a second. But we also now understand a little bit about the fact that when you create lesions for pulmonary vein isolation, of course, you're working with a 3.5 millimeter catheter in the setting of an RF catheter, or with a cryo balloon, which is an occlusive balloon. And the cartomapper, or your arrhythmia mapper, or your Abbott mapper will create lesions, either 4 millimeter, 5 millimeter, 6 millimeter dots. And one of the concepts that was taught was you just need to make sure the dots are touching each other so that you create pulmonary vein isolation. But we're not drawing dots. We're actually trying to electrically dissociate tissue, and we forget that there is the epicardial layer that we have to make sure that we address well. So this was a paper from Rottung where they looked at the dissociation between the epicardial signals, two high-density grid catheters, one epicardially and one endocardially, looking at to demonstrate the fact that you have association between the epicardium and endocardium. And this comes back to illustrating the concept that every study, small or large or retrospectively, that has looked at this has consistently shown no improvement with posterior wall isolation. And this is the paper from a group in South Korea that looked at trying to isolate the posterior wall and demonstrating posterior wall isolation, but no impact on AFib-free survival with Kaplan curves that are basically overlapping each other. And similarly, multiple studies said, okay, well, they didn't use the right catheter, let's do some better catheter techniques, contact force and so on, higher power, shorter power, longer duration. A variety of different approaches have looked at this, and Kaplan-Meier curves are unfortunately almost superimposable. This is another trial from North Carolina, a retrospective study of nearly 600 patients, and unfortunately, the same concept repeats itself, that even though we believe that something else needs to be done besides pulmonary vein isolation, we're not able to show it. This is an interesting paper from Denmark. The Danish study looked at targeting besides pulmonary vein, looking at non-pulmonary vein triggers, and the abbreviation CRZ stands for the targeting non-pulmonary vein triggers from the center to right carinal zone. That's what the CRZ stands for. So if you looked at the non-pulmonary vein triggers, they're obviously there in the right atrium as well as the left atrium. But in the left atrium, they were relatively more clustered around right carina. And so the concept was to not expose your patient to the risk of a full posterior wall ablation, but targeting just the right carinal zone from a center of the posterior wall to the right carina. This was the most recent paper from earlier this year, looking at the Kaplan trial, looking at pulmonary vein isolation with posterior wall ablation. This is a randomized. This was a multi-center. Australia, Canada, and the UK participated with 11 centers and a large cohort of patients. And unfortunately, despite this comparison of pulmonary vein isolation alone versus PAI with posterior wall, Kaplan-Meier curves are unfortunately superimposable, and this is from earlier this year. This is another interesting paper that again came out earlier this year. It's called the Party PBI study, and this trial allowed they looked at 367 patients with durable PBI, and they allowed any approach that the EP operator felt was beneficial. So if you felt EGM, I'm going to target complex fractionated electrograms. If I'm going to target non-pulmonary vein triggers, if I believe in alcohol ablation of the vein of Marshall is the only way to go, true posterior wall ablation, a variety of different options. And they looked at first procedure as being pulmonary vein isolation alone. And if there was a recurrence, that the second procedure would be first confirm that the vein was isolated. And at that point, a choice of whatever linear lesions you want, EGM-based approach, you can restrict yourself to a repeat PVI alone or multiple combination of strategies. And as you can see, Kaplan-Meier curves again, unfortunately superimposable. And the only thing that came out of this was that the left atrial size, which goes back to the model of the stiff model that we talked about, stretch inflammation, fibrosis, it leads to persistent atrial fibrillation. The only thing that came out of this was the longer you let the AFib fester, the left atrium remodels, and one surrogate of that is the left atrial size. And so the success rates of this type of patient progressively decrease. I'm going to switch to give you some examples of what we have seen. This is a patient, unfortunately, not one you want to see when you see with presenting with atrial fibrillation. This is a diseased atrium. And with CARDO, you can actually do a volumetric analysis of the left atrium when you map with CARDO. And even here in Texas and in Houston in the medical center, unfortunately, we get referred patients where the CARDO volumetric analysis of the left atrium is well over 100. In this patient, it was 249 cc. In fact, to make my top 10 list, the left atrial size would almost have to be 300 cc. And so it's 300 cc is about the size of a normal heart. And you're talking about a left atrium alone being the volume in that. And it's not reasonable to expect that you're going to do something and restore sinus rhythm in those patients. So in this picture, again, the more purple it is, the healthier the tissue. And you're setting the bar at 1.5 or so, and as you go progressively towards red and gray, you're coming down towards 0.1 millivolts. And this was from a previous patient. This patient had had a previous ablation, and the operator had basically tried to say, I'm going to go after the posterior wall because the pulmonary veins were largely self-isolated, so to speak. The patient was in persistent atrial fibrillation when he came to see the previous operator, and they had said, I don't know what else to do, but I'm going to try to target the posterior wall. And you can imagine the risk that the esophagus is exposed to when you are applying this type of a lesion set to the posterior wall. It's a very high risk for a fistula. In any event, this is the patient actually. This is a 73-year-old woman with non-ischemic cardiomyopathy. Unfortunately, long-standing persistent atrial fibrillation. And when I say long-standing, well over 1 year, in this case, she had atrial fibrillation for 8 years. And when you refer a patient with atrial size at 54 millimeters, notwithstanding this is the ablation that you do, you're going to come back with, in this case, atypical flutter, where, the patient is still exposed to a risk of stroke and the risk of worsening heart failure, and the patient was markedly symptomatic. So we took her for this study, and let me see if this video will play for you. This is with something called coherence mapping, and we were able to find a area of slow conduction in the midpoint of the roof. And as I showed you with the arrangement of the septopulmonary bundle and the Bachman bundle just anterior to that, this is an area where it is not reasonable to expect that you're going to apply one set of lesions and you can penetrate through to the epicardium. You may not. And so even though the previous set of ablations were done, in this case, we found the critical isthmus was the point where the green dot is shown. We terminated it literally at the point of ablation, but we went on to extend that line of block between the two superior pulmonary veins so as to create a durable line of block. Let me see if this video will play to show you. I wanted to show this video without the other lesion sets but you'll see the ablation catheter behind that. And literally you see the vector of the ablation catheter, and you see the termination of the atrial flutter. And that was on a single point burn, and then we went on to extend that lesion set. Now, unfortunately, what if this patient had come in with that flutter, but by the time you took the patient to mapping with this flutter, but by the time you took the patient for mapping, had gone back to sinus rhythm, or somebody had decided to cardiovert the patient instead of doing just a TE to make sure there were no clots. We had several patients that we dealt with in this situation where we were wondering what would be the best approach to them. And we decided to look at the correlation between zones of slow conduction in regular rhythm. So a patient presents, obviously with that EKG from before, but now in sinus rhythm. So we looked at the correlation between zones of slow conduction during sinus rhythm or with atrial pacing, and whether those zones would also then be incorporated in a setting of an atrial flutter. And as you can see here, this is a picture with a mapping with a high density grid from an Abbott system. And you can see the grid over there on the left side of the screen, and you can see the signals that it shows, highly fractionated signals that extend from the pace complex. In this patient, luckily we were able to reinduce that same flutter, and you can see the whole electrogram of the flutter cycle length is in that exact same area. So remarkably, we actually did this during the COVID time. We still had patients coming in with worsening heart failure because of atypical flutter, and we were able to publish this data as a hypothesis building, just not as a proof of, more as a proof of concept that needs further study. What do you do with patients when they have been referred to you after AFib for 10 years or 9 years or 8 years after multiple antiarrhythmics and 5 cardioversions? It's unfortunate, but we still see patients like that. And so, and given the complexity of trying to reach the epicardial side, one approach was to say, why don't we have a hybrid approach? And when I talk to patients, they are there to see an EP doctor, and they are very alarmed that I'm suggesting to them that they should go see a surgeon. And so because they are having concepts that they're going to have a chest open and sternotomy and so forth. And we try to talk to them that this is like a robotic procedure, but the hybrid convergent procedure tends to incorporate epicardial ablation to address all of the concerns that I spoke to thus far. And it's called a convergent because the EP and the surgeon converge onto that left atrium and the atrium in general to try to minimize that burden. There are, of course, so the question is, would you approach the EP aspect first, like an endocardial ablation first, or the surgical approach first? And having done them both ways, my preference is to have the surgeon deal with it first for a variety of reasons. But one simple reason is it makes my life easier. But let's assume you talk to the patient, but most of the time the patient is not willing to see the surgeon. They go, no, you're very good. I heard you're very good. You should do the ablation. And so they want the endocardial ablation first because their life is a lot simpler. And they heard a friend who had a good result or something else. The problem is when you try to extend the lesion set beyond the pulmonary vein, you also land up creating pericardial inflammation. And so sometimes you create adhesions where you make your life very difficult for the surgeon. And in a few patients, the surgeon couldn't even do what we had asked of him at a later date. So if we have switched our approach in the convergence patients, as they described in the study, to having the surgeon approach the patient first, and then the EP goes next. So that brings the question of when is next? Is it in the same setting? Is it later in the same day? Is it the next day? How far do you wait? And when we looked at trying to, and the reason to look at the same day or the next day is that the patient is only intubated at one time.
and that, we were looking out for trying to minimize the amount of exposure to the patient as well as. The problem is that the success rates are lower when you approach it the same day or the next day, and the complication rates are higher when you approach it the same day because it's a significant insult on the atrium. And when you approach endocardially, an ablation just done epicardially, the atrium looks shut. It looks like there are no signals anywhere. And the purpose of to approach this endocardially is somewhat lost. So the ideal concept for me for a convergent would be you convince the patient that it is in their best interest to see a robotic surgical colleague of mine. This does not involve sternotomy. It involves a 1-inch incision in the subxiphoid space. And I'll show you some slides about that, where the surgeon then extends a cannula that goes into the transverse sinus of the pericardial recess, and then ablating away from the esophagus using radiofrequency, looking into the cavity of the left atrium, and then can address the posterior wall to the extent that you want. And that might, and based on the data from the study, and based on the data that we have from all the endocardial approaches to the posterior wall, I think it may relate to the fact that because we're getting a true transmural lesion and that we are impacting the arrhythmogenic substrates in the epicardium, that our results are better. So this was a study done in 27 centers with 153 patients with a 2-to-1 randomization with the hybrid convergent arm or simply an endocardial ablation with whatever technology you choose to have with PDI, and, if you wanted to do a roof lesion or not, or other linear lesions, compared to epicardial ablation with a cannula that went into the transverse sinus over there and complete elimination of the posterior wall. Now, the data was, for the first time, significantly better with the convergent approach. Certainly, our patient gets this procedure for long-standing persistent atrial fibrillation, especially with large atria, irrespective of their EF. And we bring them, we send the patient back home with some anti-inflammatory agents. We use a little bit of steroid pulse dosing with a Medrol dose pack equivalent to decrease the inflammation of the pericardium, and some colchicine, antiarrhythmic. We continue the anticoagulation, and we bring the patient back in about 8 weeks to 12 weeks for endocardial ablation. And with that combination, the results are significantly different in the Kaplan-Meier curves. Whether you look at without antiarrhythmic drugs or with antiarrhythmic drugs, there is significant outcome. And of course, one benefit is that the surgeon has also clipped off the left atrial appendage, hopefully under TE guidance. There is the potential for being able to come off anticoagulation in about 2 or 3 months after the endocardial ablation. Now, the cannula this is slides courtesy of AtriCure, which is the company that we use for the epicardial ablation. And look at the catheter. This is obviously I've put in an typical ablation catheter for comparison. So it's like at least 2.5, 3 times thicker. And this catheter is taken in through a cannula in the retrocardiac space, and this radiofrequency filament is ablating away from the esophagus, looking into the atrium, and so linear ablation, and then you swivel it like a windshield wiper progressively, and we've combined this with mapping. So we map at the baseline, because once the cannula goes in, you can connect this to a mapping system, and it takes literally a minute or 2 to map it, and then the surgeon proceeds with what they want to do, and then you can map it at the end of the case to make sure that you've done your job and you don't have any, linear stripes that you have to go back later. Now, interesting, the surgeons, we call it distal and proximal from an EP standpoint. Surgeons call the distal end called the toe and the proximal called the heel. So I thought that was curious. Now, with that approach, this is the kind of posterior wall that you will see. This is not gray because somebody rendered it gray. This is completely gray. It does not mean that we don't ever see any flutters. We do. And so the convergence procedure, as described by Delurgio, has actually been progressively modified even from that paper. In this case, you can see the grid. In this case, this is with an Abbott mapping system, is at the base of the left atrial appendage. And this is, again, a view of the left atrium from posterior approach. And you can see the level of fractionation of that signal at the base of that appendage. And the patient is in a slow atrial flutter. And when we map this, we found a critical isthmus about that same site, just behind the left atrial appendage and just anterior to the left upper pulmonary vein. And we were able to terminate that with literally one burn in that spot. But look at the amount of work the surgeon has already done for me. He's completely ablated the veins. The veins are electrically isolated. The posterior wall is ablated. All I needed to do was to make sure that I took care of that zone between the left atrial appendage and the left upper pulmonary vein, and we have sinus rhythm. But and similarly, this is another patient where there was a gap in the septopulmonary bundle and the roof of the left atrium, and we were again able to target that with a single spot of ablation and restore rhythm. And this is led on to the improvement in the convergence procedure called the Convergence Plus. And the Convergence Plus is basically includes a set of additional things that the surgeon does, largely to help the EP doctor come back later and appear like he's the hero or she's the Sama's there, so she's the hero of the situation. So the Convergence Plus option includes LA appendage clipping. If it is not done under TE guidance, you really don't know that you've isolated the appendage. And unlike a Watchman or an amulet, the clip is entirely epicardial, so there is no need for, you could make the case that you don't need immediate anticoagulation, etc., but we do, because we bring the patient back for endocardial ablation. The Convergence Plus option includes interruption of the vein of Marshall, septopulmonary bundle ablation or the Bachman bundle ablation. We can ask the surgeon to ablate the anterior mitral line if you think you're going to need to do that later. Now, obviously, the surgeon finds it difficult to get into the true retroaortic space at the mitral annulus, but that is easily approachable endocardially. And the tougher part of the anterior mitral line, for those of you who have done it, is the superior portion closer to the roof and the dome of the left atrium. And that's where gaps arise when you go back for recurrence. And then the most important lesion is between the base of the left atrial appendage and the anterior left upper pulmonary vein. And that then makes the job of when you go back in 8 weeks later a lot simpler. I'm going to stop for a second to again plea for earlier referrals for atrial fibrillation patients. And this is from the European Society guidelines from just couple of years ago, especially not only for all patients, of course, but especially for those who are getting older with higher CHA2DS2-VASc scores, especially when you're already beginning to see the left atrial dimension creep, those with early stages of renal dysfunction, definitely those with heart failure. But the amount of data that we have for heart failure and atrial fibrillation, it would be a travesty not to refer patients with heart failure with atrial fibrillation to an EP colleague. So this is just a plea to refer earlier to your EP colleagues. I'm going to switch gears because this is the new exciting era of pulse field ablation. It's not yet available in the United States, so whatever I present here is data, but it is extremely exciting. This is a completely different technology which looks at high amplitude electrical pulses, microsecond duration of application, where the energy causes irreversible electroporation. This is technology that was available years ago to create a reversible electroporation to allow for chemotherapeutic agents to enter hepatic tumors. And the concept was just extended to say if you apply or change the application of the energy, you could create potentially irreversible electroporation. So you create these nanopores without tissue heating, no coagulation necrosis, and the energy has a much higher sarcolemmal membrane sensitivity and therefore can provide you much lower collateral damage, literally able to see pulmonary vein isolation in seconds. In this study from Vivek Reddy and others, the total time for energy delivery in the left atrium was less than 60 seconds, which is remarkable compared to where we are from radio frequencies. So it is truly exciting. I think this technology becomes available. If it doesn't become available within a year, I'll be very surprised. So this is just a cartoon to show that the exposure of the risk of the phrenic nerve, which is a little bit higher with cryo, and again, we can also get the phrenic nerve with radio frequency and of course the esophagus. Those concerns are somewhat mitigated because the pulse field ablation demonstrate a much higher myocardial sensitivity. There are different companies working on this, and because I have not used it, I won't get into which one is better because I don't know yet. But all companies are working on it. I think Medtronic is first to the field, and soon to follow is probably Boston Scientific, but I am sure Cardo is very close, and Abbott is working on something. So I know everybody is working on some iteration of this technology, but I think it's exciting because the acute isolation rate is very high, like 99%. And this was a short study looking at invasive remapping in a quick follow-up, which also showed very high. And then, of course, with the multinational PFA registry that just got published, which was a observational registry of 1,568 patients, both paroxysmal and persistent patients. There was I think LA size in these patients were 42 plus millimeters. There was a 78% AFib-free survival in 1 year, which is pretty remarkable. So, and that is from the Manifest PF that came out in circulation. These are just slides to show that with RF you actually get coagulation necrosis. And with PFA, you don't damage even the microvasculature, potentially the aorta, esophagus, etc. I think I may have exceeded my time already. I will stop with this slide again with a plea to earlier referral to your EP colleagues, because with the emerging technologies, someone like Sama could finish an AFib ablation in about 15 to 20 minutes. And then that lends itself to remarkable improvement. I will stop there, be happy to answer any questions, and I thank you again, Sawan, for the invitation and for the opportunity to share these thoughts.
Thank you so much, Dr. Ramesh, for this excellent presentation and overview on the different technologies and the outcomes on these. I think, are we connected? Yes. So now this session is open for questions.
I think so, yes. Thanks for the great talk. Yes, so my question is all for all the EP guys here. It's not for a specific one. So let's say there's a patient with an AFib, sleep apnea, that's also got treated, and the patient underwent ablation. He had an event monitor installed in him previously for diagnosis, to do the diagnosis. He did the ablation. Ablation was successful. Now we are following him for 2 years. There's no events. And the patient asks you, can I stop anticoagulation? No event, 0 events for 2 years. And he's just taking anticoagulation for himself, for no reason, and for myself as well. I believe it's for no reason as well. So what's your take on this?
So we'll have you, Dr. Ramesh, to answer this question, please.
This is the $1,000,000 question. This is what patients want to come and see us for, because their first impetus is to come off the blood thinner. So what I would tell the patient is that the data we have shows that the stroke risk is not directly correlated with the immediate presence of AFib. In patients with devices, we've seen that it is a marker of the stroke risk. And so if the CHAS-VASc score is high, beg your pardon, unfortunately, at the time of the stroke, and we've correlated this with patients who have devices, they may actually not be in AFib at that particular time. And so it's a very dramatic thing to see that the CHAS-VASc score is 4. The patient is in sinus rhythm, as noted by your atrial lead, and you have a stroke. And so it's very frustrating when you see that. So now there are patients who still want to come off, and I tell them, and they want to monitor it with their AFib watch or so forth, and I tell them that's probably not optimal, because you have asymptomatic AFib, and then you may not be correlating with any symptoms, and you're not monitoring during the night. Several of my patients have an implanted loop recorder, and they want us to do their job for them by monitoring us for atrial fibrillation. And if their CHAS-VASc score is low, I say, okay, we'll try this. This is not the ideal way to do this. We are involved in a trial called the Catalyst, because the current regulations that govern left atrial appendage occluder implants relate to inability to tolerate anticoagulation, so high bleeding risk, frailty, and so forth. Hasbled scores have to be high. But the Catalyst trial, and there are trials looking at a choice where nobody wants to be on anticoagulation, so would there be, how do you judge the risk exposure from a highly invasive procedure with complications versus the ability to take blood thinner? But watch this space, because this space is rapidly changing. Currently, we probably don't use so much Coumadin, although there are situations where we do use Coumadin, warfarin, but we use more of factor 10A inhibitors and factor 2 inhibitors in the form of dabigatran or apixaban or rivaroxaban or edoxaban. The new class of compounds that is going to be coming out very soon is called factor 11 inhibitors, which are markedly lower bleeding risk, potentially can be given by a sub-Q injection once a month, but with as good or better anticoagulant efficacy. And so that will change the paradigm in terms of willingness of patients to be able to take. So factor 11 inhibitors are already being evaluated. Atrial fibrillation, but also in the operative setting for knee replacements and hip replacements, etc. Thanks.
Thank you. I have another question, actually, if I may. Sorry, I have a lot of EP questions. Samah have been answering the whole time, but I still have EP questions. So now, you guys insist saying that for asymptomatic patients, you can treat medically with a rate control and just anticoagulate, and that's it. And you keep following those patients in the clinic, you keep repeating echoes, and you see the left atrium in the front of you is actually dilating and patient losing his AF, and then you send them eventually for AFib ablation, or maybe you lost your window at that time because the LA is so huge. With the with the advancement in AFib ablation nowadays, Dr. Fawzia, Dr. Samah is doing their AFib ablation within like a few hours, like an hour or less than an hour, they will do their ablation. Do we really have to wait for patient to be symptomatic to send for AFib ablation? Is it still a thing?
I think we'll still have you to answer this, Dr. Ramesh, if you don't mind.
Sure. So, I mean, there are obviously, this is the question as to when do you decide the patient is totally asymptomatic. the approach for a 40-year-old or 50-year-old patient is clearly not going to be the same as my 84-year-old mom who's just basically, not wanting to do too much and so forth. But we don't know is the answer right now. But at a minimum, what I think you should do is to at least cardioverse the patient one time to assess whether the patient is truly symptomatic. Very often, unfortunately, what happens is, and I just go back to reflect on my dad who had extremely bad arthritis, but totally asymptomatic. Why? Because he wasn't doing anything. He would basically get up and sit in a chair and a table right next to his bed. His meals were brought to his side. And if you ask him, how are you doing? He goes, I feel great. He has no limitations because he's not doing very much. So the question of asymptomatic is something that we easily apply. And there just needs to be a little bit more care before you label somebody truly asymptomatic, especially when they have a long runway of time, and we lose out on all the opportunities. And this definition will again change when we have something like pulse field ablation, and you can complete an ablation in an extremely short time, sometimes even without general anesthesia. And then we will be revisiting this question. But and the guidelines on this are really behind. And I've said this to people who write the guidelines, because they're not in keeping with what my patients want. They're not in keeping with what my cardiology colleagues want. The European Society guidelines are a little bit more progressive than the American guidelines, but this will be a rapidly changing field as the technology improves. I just would caution people to pay a little bit more time with the patient before you render somebody as a statement saying truly asymptomatic.
Maybe I want to thank Dr. Hariharan for your talk, and it's a pleasure to see you from through the screen. So this is me, and I would like maybe to ask Dr. Fawzia to comment, since she's actually pioneering pulse field ablation, and she's the only one in the room who started this technology. So I'll be eager to see her experience on that regard.
Yeah, I think I have started the pulse field ablation, like I would say in December 2022. So far, I have done like 43 cases with the pulse field ablation. I see the technology. I think it's coming really very strongly. I was doing the RF, I do a lot of cryo, and then we introduced the pulse field ablation. I can see the difference between the three technologies. Mainly, number one is the time. We are doing now pulse field ablation from the start to the end, 25 minutes. So it's really great. I started to have more of these patients done under deep sedation rather than general anesthesia, at least most of the patients, and it is becoming more and more a practice, so it's much easier for the patient not to have a general anesthesia. Of course, still the risk of, again, esophageal injury, risk of phrenic nerve injury is definitely, is not there, at least. Although I know there have been some rare presence of cases of phrenic nerve injury, although it was transient. And it probably could be related also partly, I can see it with the anesthesia when they give a lot of muscle relaxant, but I have been noticing this, so there has been no single case of phrenic nerve injury. The only thing, the drawback with that is, so far is the fluoroscopy. So you definitely need to have the fluoroscopy between in the pulse field in all these cases. So I think it is a very good technology. So far, the results we know, from the studies that are coming, that it is at least equivalent, the acute success rate is equivalent to the cryo and the RF. I think we don't have the long-term results from these, but we have to wait for that. It's definitely more convenient for the patients. I would say I think this is, especially if we're going to combine it with a 3D mapping. I have done maybe 2 cases with posterior wall ablation with the pulse field ablation using the flower, but still we are not advanced yet to do it with the 3D mapping. So I think that the Boston people, they're going to come with the arrhythmia part, and of course their catheter is also coming. It's not only the faraway. So this is my experience, but I feel that this is coming as a very strong technology, at least saving a lot of time. That will make the flow of AF patients is definitely much faster and easier.
Thanks, Dr. Ramesh, for the excellent presentation, and we are happy to have our pioneers, Dr. Sameh, Dr. Fawzia, and the others in this room. I want to ask you, I have a patient that have done AF ablation, and at that time she was 63 years old. So they did not prescribe for her anticoagulation because her Chad Vasc was only 1. Now she came to me, she's now 66. She feels palpitation like before when she had AFib. I did her Holter 48 hours. However, she said that she didn't have the same attack. Do you recommend for those cases loop recorder, or shall we continue without anticoagulation? Thank you.
Yeah, so if you're not sure and you if you're not sure of the arrhythmia diagnosis and you don't, let's assume you did a Holter and she had symptoms and there was PECs or something else, you have the ability to reassure them and say you don't have AFib. But if you don't know, you didn't catch the episode, you really don't know, and then I tell the patient, listen, until you know for sure, this would be a recommendation. You're a woman, you're about 55, and your CHA2DS score then becomes 2. This is something to at least have a conversation with the patient. They may or may not want to do this. Now, if they are only talking about symptomatic episodes, a lot of my patients want to do it on their Apple Watch or Android Watch. But in order to pick up asymptomatic episodes, especially a lot of episodes of atrial fibrillation post a previous ablation can be asymptomatic. An event monitor would be very useful to have. I don't think everybody needs a loop recorder, especially if you are looking for a 4-week, but some patients do. So that's my approach to those patients.
So, any other questions, please, from the audience?
One comment, maybe we can all discuss this since, I mean, from different centers, we all have the same message that we have late referral. Patients come to us late with dilated atria and usually even low EF. So what do you suggest that can be done to overcome this so that we can give the patient at least longer sinus rhythm as much as possible and early intervention?
Don't lose hope. When ACE inhibitors were introduced, it took average time lag between evidence-based class 1 recommendation medication to institution in general practice is about 17 years, according to studies that have looked at this. So I think as patients see AFib ablation is still seen by, it's quite sad actually, but it is still seen as something that takes 6 hours and it is useless. It has really got multiple, complications and it doesn't work and so forth. But it is something that we keep at it. We have moved on from maybe 1 or 2% population of AFib to maybe 10% of AFib. Still the vast majority of patients with atrial fibrillation go untreated. sometimes not even anticoagulated, and then they land up with heart failure and a stroke, and it's really sad to see at that time. But I think as the technology improves, and there is already conversations, for the first time there is direct-to-patient marketing, at least in the US. You know, someone like Kareem Abdul-Jabbar, who's a very big basketball player, is talk just about anticoagulation, not really about any technology or anything else. Simply, I heard a radio ad while I was driving the other day of him just talking about, go talk to your doctor about a blood thinner. I think that was a good place to start. And we've definitely made a dent in coronary disease. It took a long time. You know, Braunwald talked about this in the 1940s and 50s, and we have now just made, so it is, unfortunately, these things take time. ACE inhibitors came out such a long time ago from the SAFE trial. Only now is it a very kind of, you know, it's common to see ACE inhibitors in people's armamentarium. So I think we just need to keep at it. It's our job to make sure that we educate our colleagues, and then starting with a primary care physician, referring cardiologists, and patients. I think it's a conversation. I think one of the things you can talk to, I don't know what the setup in Kuwait you have, but a couple of things we've done in the Woodlands, Sama, which is a suburb of Houston, is what we call coffee with a cardiologist. You have an open forum. They're not patients. They're just people who are interested. You set up a pot of coffee and some, you know, snacks for breakfast, and people come and ask questions and increase awareness. And the hospital does it on a day when they have a farmer's market, and they do this in terms of increasing awareness. But this is just increasing community awareness. This is just a constant process that we have to do. And anytime you go to a place which is brand new, so I do a lot of outreach, and Saman knows this, even though I work in Texas Medical Center, I go to places 3.5-hour drive away from Houston. So it could be Lufkin or Corpus Christi. And the referral there for AFib only occurs when the patient is in a crisis. And that's where I see left atrial sizes of 350 cc by volumetric analysis, or 330 cc. It's remarkable, you know, and they had the opportunity to be referred a lot earlier. And so that's one of the reasons I see the impact I make, and that's why I go to these places. Not because I need to go to any of these places. It's just something, it's a personal, lot of personal effort. You know, you have to increase awareness to patients, colleagues, primary care physicians, and use the opportunity to go on TV to give talks.
This is what we're doing today, and yes, I think among everybody here in the room, I think we're all playing our part. So I think small steps, we're probably gonna reach somewhere better than this. Any other?
Just one question, Dr. Ramesh, for the hybrid procedures. How frequent do you do it? I mean, in your real practice? I mean,
so we've done we're talking about 40 or 50 patients. And again, not because we couldn't do more, but because patients are not keen to see a surgeon. But when we see them and they've got left atrium that is really dilated, their EF is 30%, and they are in persistent atrial fibrillation, and they've had AFib for 7 years or 8 years, I tell them, I'm going to be in your heart 5 or 6 times if I'm going to only do this endocardially. This is not the way to go, you know. And some only accept it after they fail an endocardial ablation. And some are more willing to trust me and say, okay, we'll see somebody. Especially when we bring them in the hospital and see how dramatically better we cardiovert them, put them on antiarrhythmic, and show them how much better life could be if they could remain in sinus rhythm. So the best time to see them is soon after a cardioversion, because you can discuss a lot of things. Patients are much more, so it's good to see them within a week after cardioversion, because the odds are high that they're still in sinus rhythm, and they have noticed the dramatic difference between what they were a week ago compared to now. to discuss real treatment options for them that are more specific to the level of disease process that they have, as opposed to simply trying to approach this. So clearly not many patients, but given the volume of patients we do, our group, we have 8 electrophysiologists. We do about 2,700 ablations, not AFib ablations, 2,700 ablations a year. And a significant portion of them are AFib ablations. But, again, the number of people who have hybrid procedures are small, not because they don't need it or they wouldn't benefit from it, but because a patient acceptance to having an incision for AFib ablation is small.
Again, one more question. Do you do any ablations combined with appendage closure devices if the patient is insisting not to take anticoagulation, and if you do it in one procedure at the same time?
Very good question. We've done them. This is, again, based on the patient request. So let's take a patient in whom they would benefit from Watchman or Amulet, where we have discussed. So first of all, I discuss with patients that their CHA2DS2-VASc score and stroke risk. But if they also have a high Hasbulat score, we've done some patients, especially when the access is difficult, they're particularly obese, where we've done even some transhepatic approaches for interrupted IVC, or we have to approach from the neck or something else, where the access is particularly difficult. We've done them on the same setting. Or for patients who really, really, really don't want to be on, and the opinion of the GI doctor and other people is that you do it at the same setting. We've done them in the same setting. But there is a trial that is going on. We are not participants in that trial that is looking at that option. And I think from a patient standpoint, it would be a fantastic thing to do if they are candidates for an appendage occlusion, that you do it at the same time. In patients where there is, unfortunately, appendage occlusion implants are highly regulated in the United States. And, it's audited and so forth. And sometimes insurance approval may not be given, and the hospital won't get paid for a combined procedure. So in those settings, what I do is I tell the patient, we're going to do an AFib ablation on time 0, 6 weeks from, and my minimum time to anticoagulate even a low CHA2DS2-VASc score patient for atrial fibrillation is 3 months. So 3 months is 12 weeks. So I do a time 0 AFib ablation, 6 weeks later, bring them back for Watchman, and 6 weeks later, stop anticoagulation. Not all Watchman patients we anticoagulate, but with the new Watchman Flex Pro, thrombus risk is low, but until recently, because of 4% DRT, device-related thrombus, we've kept them anticoagulated for a short time, if they could tolerate it. And otherwise, we can switch to aspirin plaques.
Great. Any more questions from the audience? Thank you so much, Dr. Ramesh, for this excellent presentations and answers and questions. And thank you so much. And hopefully we can see you in a very near future in other meetings. And things have changed, and we have much more improvement in awareness in atrial fibrillation and more new data. So thank you very much. Thanks a lot.
And I'd come just to see Sama. I love it. Thank you, Sama, for the invitation. Really enjoyed being part of your meeting. Thank you all very much.
Thank you.
Best wishes. Bye-bye.